Welcome to Brain Wellness, the podcast. I'm your host, Mandy NP. Each episode will bring you a new topic or interview related to brain health and wellness as part of my mission to help you on the path to a healthier, happier brain. So, let's get started. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. My guest today is Dr. Mike Stone. Dr. Stone is a board-certified concierge medicine physician committed to fostering deep, meaningful connections with his patients. He holds a degree in biology from Brown University and graduated from New York University School of Medicine. Dr. Stone has served as an associate professor at Harvard Medical School and UCSF. Recognized with national awards for his contributions to education, innovation, and leadership, he is passionate about exploring what it means to live a joyful and fulfilling life. Dr. Stone integrates lifestyle interventions, precision medicine, and consciousness expanding therapies into his practice, helping you achieve physical, mental, emotional, and spiritual health. His approach is rooted in a holistic understanding of wellness, emphasizing the importance of connecting with patients on a personal level to support their journey toward vibrant and fulfilling lives. Thank you so much for being here, Dr. Stone.
Thanks for having me. It's a pleasure.
Yeah. I love when I can connect with people all over the United States, the world, and we can have conversations where we realize that we really are all here for the same purpose. So I'm
Mhm.
always excited about that. So my first question to everybody is always, tell me a little bit more about you. How did you get to where you are in medicine? What brought you to where you are today?
Yeah, so I took a very traditional allopathic medical training route. So I went, I guess the one way I was non-traditional is I didn't go straight into medical school from undergrad. I was late to realizing I wanted to do medicine or maybe accepting it. And I spent some time in between undergrad and med school doing computer science, but really more like computer tech support, which I had no idea would probably be the most valuable training I ever had for my adult career was learning how to work computers and troubleshoot things. Um, I did my MD, as you mentioned, at NYU, and then I went into residency for emergency medicine out in the Bay Area, and basically did 15 years worth of academic emergency medicine, so training physician assistants, interns, residents, other faculty, publishing, speaking, back, and then working, I probably saw 40,000 patients over a 20-year career in the emergency department. And right around 5 years ago, I just really knew that it was time for a change. I was very frustrated by the feeling of helplessness of seeing folks coming into the emergency department with acute exacerbations of chronic illnesses that were very preventable or treatable, just not in the system that I was working in. And that could be anything from, cardiovascular disease to metabolic disease to obesity to cognitive issues. And, I have no regrets about 2 decades in the emergency department. I think we did a lot of good for a lot of people. And I think Western medicine definitely, if I'm hit by a bus, I want to be seen in an emergency department. But it was just time for a pivot to kind of dive deeper into seeing what I could do to really impact health in a more holistic, meaningful, long-lasting way for folks. So that was the beginning of my evolution into what I'm doing now.
Yeah, that's a really, I love when people kind of take that little detour. You got to figure out who you are first and figure out what you want to do. I too took a college course on computers because I didn't have one in my house growing up. So that was also very helpful in my practice. It's good background to have, especially running a service where I'm assuming you're doing a lot of it on the computer now.
Yeah, so I do have some folks I take care of who are local in my area in Oregon, but I have folks I care for who are all over the United States. And I mean, we do a lot of data ingestion and tracking and biometrics and wearables and all sorts of tech that we incorporate into the practice. So that yeah, I really mean it. That year of learning how to take the top off of a computer and troubleshoot something, and I think the internet was. I mean, this is just more evidence about how fast time goes. I think the internet was maybe like 2 years old, really, at the time that I was doing this. So, yeah, paid off in dividends for just practical ability to function in today's world.
Absolutely, absolutely. So, what was it like going from emergency medicine to concierge medicine? Those are two very different worlds.
Yeah, I mean, it's really a 180, right? I mean, you're going from I think the average time that a Western physician, and I think emergency physicians would be at the sort of shortest end of this time, allows a patient to speak before they interrupt with a question is something like 8 seconds. And just to go from these 2 to 3 minute interactions that to I don't meet with people for, I mean, unless it's a quick question that somebody texts me or something, I don't meet with people for less than 30 minutes. And it's not 30 minutes of me typing on a screen. It's 30 minutes of one-on-one deep connection and conversation. And I think that was the biggest change, frankly, was just like really getting to know people and connect with them and form relationships and understand what's really important to them. And I think, it's no fault of anybody, anyone listening who's had a suboptimal emergency department experience. I'm sorry. And it's not the nurses, doctors, PAs, NPs' faults for that experience. That is the system and the way it is built. And when you have a waiting room of 40 people and all the beds are filled in the ER, you're going to wait in the waiting room or you're going to be seen in a hallway. And you've got one doctor to see every single person overnight on an overnight shift. You're going to wait a long time. You're going to have short interactions. And it's really, it's just a tough system to work in and to really be able to step out of that and take a deep breath and really connect and hear people, that's probably the biggest satisfier for me in terms of that change.
Yeah, that's as a nurse practitioner, I've always been afforded the ability to have a little bit more time with my patients than physicians do. But I do recall several times having to evaluate a patient on a gurney in the hallway because our emergency room was full. And that was for a stroke evaluation. So, that's always an interesting place to try to figure out, am I running to CT with this person from the hallway or not? So it's a different type, it's a different world in the emergency room. And I didn't do it full time, and I still um, loved my time individually with clients much better and patients.
Yeah.
So,
And I
yeah,
mean it's also it takes a toll on the people who have to work there
yeah,
or who choose to work there. I mean I chose to work there. I didn't have to work in the emergency department. I not tooting my own horn, but I did well in medical school. I could have gone into a different field if I wanted to go. It wasn't like it was my last choice, it was my first choice. And um we really didn't know in 99, 2000, like didn't really know that sleep deprivation over and circadian rhythm disruption over a 20-year career actually has deleterious side effects, not to mention the stress, the food that's sitting out in the emergency department at 2 a.m. for people to eat, the for staff to eat, the just so many aspects of working shift work and abnormal hours and high stress situations. Like it takes a toll on emergency workers. And I think as a society, we don't really pay that much mind. I think there was that quick 15 minutes of fame during COVID where people would like bang their pots and pans and celebrate the emergency staff. But that lasted for a week, maybe, right? And it does. I feel grateful to have been able to do that job and to provide that service, and to also grateful to not be doing it right now.
yeah, yeah. I was going to say, how is your own health now that you have stepped away from the emergency room?
Yeah, I mean, I give talks to groups not infrequently, and one of the I usually start off with a case study that I don't tell them is me. But I start off with a case study and I show these, laboratory findings with just, terrible cholesterol and some metabolic disorder and metabolic syndrome, basically some mild insulin resistance and body fat percentage high, skeletal muscle mass low, blood pressure borderline, and then all of those labs, blood pressures, body mass indices, what they looked like a couple of years later, which have all been like really optimized at this point. And then I flip to the next slide, and I've got me standing in front of an emergency department and then like 6 years ago, and then me in the woods like 6 months ago. And it isn't a victory lap like, oh wow, look how well I did with improving my health. It's really meant to be disarming and to have a few different impacts. One, to be disarming, to show that I'm just a human and not just a doctor. Two, to say, it's not too late. I was in my 40s when I really got a handle on healthy living and what that really looked like and felt like and meant for me. And that it's it's pretty dramatic what those changes can look like over a short period of time, and it's never too late. So that all of that said, to actually answer your question, I got a hold of my own health. And in the process of learning how to really do that, which was not going to my primary care physician, allopathic MD, and getting a pill for something. And I'll put a pin in that and just say, I'm not anti-medication. It can be thoughtfully used in a way that's incredibly useful. But the sort of pill first strategy of Western medicine and everything's a disorder and here's a pill for that disorder. I think I'm just seeing you nodding. I think, this is not, I don't think this is the right way to practice medicine as an ideology or as a philosophy. But I fixed my own health through lifestyle intervention, nutrition, sleep, physical exercise, community, stress resiliency, and got it significantly better. And then I also needed some help with some medication to get it to an optimal level. But it was my own journey through, sort of my own health journey that really inspired me to do this like full on and to just be this, to have this style of healthcare be what I dedicate my career to.
Yeah. Yep. And sometimes it takes that personal nudge that you have to have that experience. My TBI that I had a year and a half ago definitely has nudged my practice a slightly different way than it was before. And your point to the medicine first not being the way to go, absolutely. And we all were kind of indoctrinated in that in Western medicine. That's what we do. We learn all the things in school. We learn about the diagnosis. We learn about the treatments, which is always medicine. We talk about lifestyle nutrition things, and there is a little hint in there when they say that those things can be more effective than medications. But, insurance requires all of these things, so you have to do the medications. So we do all of those things.
Yeah, and I think there are a couple of secrets in the not to be all like conspiracy theory. I don't think they're conspiracies. I don't think they're deliberate secrets. I think it's just institutional knowledge and it's just the way things go. Where like is no fault of anyone, but I think there are a couple of secrets about what is taught in medical school and what is actually practiced and the disparity between those two things. So on one level, um, when you go see a primary care physician and your blood pressure is elevated or your body mass index, not a great marker, as we all know, but let's say you're obese. And lifestyle first is always what you learn in medical school, right? So, and granted, it's pretty rudimentary, maybe eat less, move more, or like healthy fruits and vegetables, which, everybody likes healthy fruits and vegetables. I'm not against those, but it's pretty simple. But then you go off into your clinical training and you do a rotation in primary care. And I mean, I remember this, the first patient that came in where the person I was observing and shadowing had this conversation, they recommended a blood pressure medication, and the patient left, and the I waited till the patient had left, and then I said, "Hey, what about like lifestyle? The eager med student. What about lifestyle and healthy eating and et cetera? We learned all about this." And they said, "Yeah, that it just doesn't work." Like in practical experience, they hadn't seen people adopt those habits, and they hadn't seen those changes, and then they just decided to kind of skip that step and go straight to medication. And the reason why people hadn't adopted those habits probably weren't resourced well enough to adopt those habits. So, a big part of what I do in my practice, I work really closely. One of my business partners and close friends is a health coach, also a nurse practitioner, but functions as a health coach in my practice. And if you're not giving people the behavioral tools, the motivational interviewing tools, the goal setting, the compassionate accountability to actually take recommendations and put them into practice and move them from being inspirational, motivational to being habits to being passions, then of course that's not going to work. And you're going to end up on a pill to manage your blood pressure. And then I think the other, deep dark secret of medical training is day one in statistics. They tell you that you can't apply population statistics to individual people, and day two you just start applying population statistics to individual people. So personalized medicine and really knowing sort of what's the right fit for the right person is a huge part of what I do. Everything from iterating on it with folks and seeing what works with them to epigenetics and genetics and really trying to get a blueprint of how that person's likely to respond to X, Y, or Z and tailoring the care and the support around the individual and not around if I give 100 people this medication, then this is the likelihood X, Y, or Z will happen.
Yeah, individualized medicine, that's the one thing that they highlighted so much for me in nursing school and nurse practitioner school was you always individualize your care plans, and then we get into practice and we don't. So I love that you're able to do that now. I work in a wellness clinic now, not as a nurse practitioner, but I work with a spine surgeon who he's been a spine surgeon for probably about as long as you were working in the emergency room as well, or maybe a little bit longer. And in the last year and a half, 2 years, he got into wellness. So he started this clinic that I work at now. And we actually have a radio show, local radio show, where we talk about all these things non-medicinal. And it's so much fun to actually work with somebody else who was also Western trained and practiced this way forever and is now realizing there's more to medicine than just what I've been doing for the last couple decades. So it's really cool to have those opportunities. And I think we could go on this whole train of thought for a really long time. I do want to get back on track a little bit. I
Let's
wanted
do
to
it.
ask you, in your bio, you talked about conscious medicine. What is conscious medicine? Is that kind of what you've been alluding to here?
Yeah, conscious medicine is how I think of what I'm practicing these days. And, to be conscious is just to be aware and to be alert and to be cognizant of what's happening in the moment. And, it really more of a response to being asked to be pigeonholed into multiple other forms of medicine. So are you a traditional concierge medical doctor? I'm not. Are you an integrative physician? I mean, I do integrate things, but I don't consider myself an integrative physician. There's lots of societal conditioning and baggage around terms like holistic or functional, all across the board. I just didn't feel like there was a good term for it. So I just made one up because it's better to have a conversation about it than it is to say, no, I'm not that exactly. No, I'm not that exactly. Um, I'm not sure if you're familiar with there's this concept of neti neti in some of the ancient wisdom traditions around not this, not that, of when you're doing an exploration of who you really are, that you're not your body, you're not your thoughts, you're not, and you go through this exercise of not this, not this, not this. And it kind of feels like medicine. My practice today feels like that. I just don't really feel like it's any of those particular styles. So to me, conscious medicine is putting the relationship with the and you'll notice I generally avoid using the term patient, and I generally avoid using the term client. That is a conscious, no pun intended, decision. The people that I'm fortunate enough to care for, um, I think putting them first, really having a almost a team sport feeling about healthcare, that's not something that Western medicine has encouraged, allowed, fostered. And I think to me, that's what conscious medicine is. It's really being hyper aware of what's important to the person you're working with and how to best not just tailor a plan for them, but to support them through the process of them discovering what health looks like for them and then helping them get to the point where they really feel like they're achieving that level of health today and not again. Oh, so here's another not this, not that, not longevity medicine, not anti-aging medicine, not regenerative medicine. Like, I think it's wonderful if people want to be focused on how they're going to live to 120 years old. That is a personal decision, and I'm fully supportive if that's important to someone. To me, I think it's far more important to live your best health and life right now in this moment, which is what's happening right now, and not be planning for what's happening 20 years from now and missing what's happening right now. So, a long-winded answer, probably not any clearer at the end of it than it was at the beginning, but that's sort of what, or maybe it is, but that's
Yeah.
what conscious medicine means to me.
I love that. It's being present right now. And I think that's a great way to go. I love the idea of figuring out what their ideas of health are because I've heard rumblings in different educational things that I've gone to for years about how you can be healthy with a chronic condition. And we never really think about that. But what does health mean to you? And what does being healthy mean to you? Having a chronic condition, you can still be as healthy as you possibly can be with that. And it's just identifying what that is. In Western medicine, we're not good at that because we say, well, you have this, this, and this, you're not healthy.
Yeah, you have a disorder, you have a diagnosis. We need to fix that diagnosis, or we need to fix the symptoms associated with that diagnosis. And, I have, um, folks that I've cared for who have, chronic illnesses that they feel like, okay, like I'm okay with that. But what I really want to be able to do is get back to playing golf or get back to skiing.
Yeah.
That's what it would mean to me to be healthy right now. Not to not have this or that or to be off this medication. But that's what's important. And I think that that's something that is, pretty universally ignored in the Western healthcare model is, the doctor or the nurse practitioner or the PA tells you what you need to work on for your health, right? And doesn't say, what do you want to work on for your health? And I always enter into this relationship where I'm not going to ignore things that I think are potentially damaging for your health. We're going to talk about them. But creating the priority list is a joint venture, right? This needs to be a conversation of, sure, we could work on losing 10 pounds of body fat and putting on 5 pounds of muscle if that's what's important to you, or we could work on risk stratifying your cardiovascular disease, or we could work on reducing your stress and fixing your sleep. And all of those things are important things to do. We're going to get to all of them. But what's the one that's really causing the most friction or that you're feeling the most unwell with? And how do we put together a list? Because you can't work on all of it at the same time. Right? You need to have some areas of focus.
Yeah, otherwise that 30-minute visit is definitely going to be much longer than 30 minutes if you're focusing on all of it all at the same time.
Well, and my one of the things I'm very grateful for around my time in academic medicine is I had a lot of experience with adult education. I was teaching adults, very high performing, intelligent, cognitively accomplished, and curious adults, and did some graduate training in adult education. And you can't talk to someone about more than three things in an encounter, or they just come away confused. And number one, the visit, you're right, the visit would be longer and you'd have diminishing returns on that visit in terms of what they took away from it. And sometimes I do meet with people for an hour if we have a real deep dive about something that we need to do. And frankly, I really kind of enjoy the hour because then the pressure is totally off because you're going to get through everything in an hour. But yeah, I mean, I think working as a team to come up with what are the issues we want to address today. And most of my visits start off with what's a win for you today, and what would you be really disappointed if we didn't address, right? And let's just start there, and then the conversation tends to hit on all the important items.
Mhm. That's a really cool idea. I like that a lot. Um, so my next question then is, you're on the Brain Wellness podcast. How did you get interested in cognitive health as part of your practice?
Hmm. How did I get interested in cognitive health? So I've got a personal story, a few around that. My paternal grandmother had pretty significant Alzheimer's disease. My mother-in-law had early onset dementia. So many people in my life who've been touched by cognitive decline. In addition to that, I have APO E3 E4. So APO E3 4, excuse me. So I've got one copy of an APO E4, so I have an increased risk of cognitive decline based on that. Um, really sort of a cosmic joke. Neither of my parents have an E4. So it's a spontaneous E4, which is like, yeah, haha, there you go, Mike. Um, and in the course of working with folks in a personalized medicine capacity and personalized health, um, I just started doing a deeper dive into the impact of glycemic variability, the impact of higher carbohydrate diet, the impact of of exercise on cognitive health, and sleep was probably the one that really threw me over into prioritizing this as an area that I wanted to focus on deeply for myself, as well as an area that I was then going to be able to bring to the folks that I work with. So, 20 years of emergency medicine, I have a lot of sleep debt. And that was really an eye opener for me. I think as the sort of ApoE literature started to emerge, and the evidence around sleep disturbance and cognitive health started to become more clear. I honestly, that was one of the factors in my decision to stop working shift work. Was I just was like, this is slowly killing me.
Yeah. Yep. Um, Nurses face that all the time with rotating
Hmm.
shifts as well. So in healthcare in general, when you're working in a hospital, you're doing those rotating shifts. It's awful for us, and they tell us about it in school, but then they still have us work those shifts. I love that you know your EPO-E status because not everybody knows that. And I learned about this 10 years ago from a neurologist I was working with at the time, and he practiced more functional neurology. So 10 years ago, we were doing this, and it's still not a big thing, but it's definitely a genetic risk factor that we should be looking into more frequently because there are things you can do to decrease your risk, such as the changes you made and the changes I'm sure that you're talking about with your individuals you take care of as well.
Yeah, I mean, it's for folks who don't aren't familiar, ApoE status, you get one gene from each parent for every gene. And if you get two copies of the ApoE3, you have sort of the baseline US risk for dementia. You can have an ApoE2 or a 2-3 that's actually even lower, but most people are 3-3, the bulk of the population. It's a I want to say it's about a 9% risk of developing cognitive decline at some point in your life. Um, if you have one copy of the E4, so you're 3-4, you've got about a 2 to 3 times risk compared to the general population. And then if you have a 4-4, you have about a 15 times risk. So that's a really high risk of developing dementia. And there are plenty of things you can do to get that risk closer to a 3-3. And, if you had to say, well, what am I going to do? I don't have a lot of time. I just need to do a few things and a few things only. Sleep optimization, glycemic control, so reducing the amount of sugar, blood sugar variability that you have, controlling any insulin resistance or diabetes, stress resiliency and stress reduction, cognitive training, like learning new skills, new instrument, new language, hormonal optimization, and then all of those, screening for heavy metal toxicity, other environmental toxins, all of that plays a role. And at the end of the day, exercise. It is still, I think, the strongest signal. I'd be curious your thoughts. I mean, you've been working in neurology for as long as you have, but to me, I think exercise is still the absolute best medicine for cognitive health.
Yeah, exercise and sleep are probably the number two things that I talk about all the time. Because you can't out exercise a bad diet for one though. So that's you still have to have your diet cleaned up a
Yeah.
little bit. But you absolutely must do it for all aspects of your health, not just for your brain, but your entire body. Women, as we age, our hormones change. Exercise is one of the number one things that we can do to protect ourselves from all the different complications that can come from lack of estrogen and progesterone as we get older. So that's a huge factor. And we don't often think about those things. The general public doesn't typically think about it because we haven't educated them as healthcare providers. So as they come through our door for getting care, they're not going to know these things. And unless we have that knowledge to share with them, they're not going to.
Yeah. I mean, I would venture a bet that the vast majority of Americans think that exercise is good for weight management,
Yeah.
right? And just
Yeah.
have never even heard of the idea of exercise being, cognitively protective
Yeah.
and neuroprotective.
Yeah. One of the best ways I tell people about it is that if you're exercising, it helps you sleep better. And sleep is where you form your long-term memories.
Mm.
So if you're not sleeping well, you're not going to have that cognitive ability to do the things you need to do at work or play or whatever. So the exercise is the first step in improving your sleep even.
And clearing out we clear out our neurotoxins overnight while sleeping, right? The fact that there was no glymphatic system discovered when I was a med student is one of the many things that makes me feel old in my career. But those were some of the studies that really kind of shocked me when I started doing a deep dive into this, that you can take people and have them volunteer. So folks volunteer for a research study where you sleep deprive them for a night. Terrible study to take part in, but I'm sure they were paid. And you get sleep deprived for a night, and then you get a lumbar puncture, a spinal tap in the morning. So definitely don't sign me up. I don't want to be part of the study. But if you do that to healthy young adults, you find beta amyloid and phosphorylated tau, all of the substances that we see accumulate in brains in people with dementia. You see spikes in that in the cerebrospinal fluid in one night of sleep deprivation. And it doesn't mean that you've developed dementia because you had a night of sleep deprivation. I'm not trying to scare anyone, but it is this dynamic process that's really responsive in an incredibly acute way to what our bodies and minds perceive as an insult, which is sleep deprivation. We don't have a chance to clear this stuff from our brains if we're not sleeping. So, yeah, it's what are the most important pillars of health? Sleep, physical activity, nutrition, community connection, stress resiliency. Those are the things that we know are the most important. And if you try and decide which one's the most important, you end up in this weird thought loop of, right? Like exercise and sleep probably have the best signal to protect cognitive health. And yet, if you're eating a ton of ultra high processed
Yeah.
foods and your blood sugar is 200, you're probably not going to have a good outcome, regardless of the fact that maybe there's not as much evidence that nutrition fosters cognitive health. It's still necessary to have a healthy approach to nutrition to be able to avoid it.
Yeah. Yeah. Although I think there still is good research to back up the nutrition part too. We just don't
Mhm.
focus on it a lot. Again, that same provider that I worked with a decade ago had, when we were reading different research articles, we identified the new terminology for Alzheimer's, which was diabetes type 3.
Mhm.
So following that same kind of diet, if you're not cleaning up your diet, that will lead to cognitive decline. So there's a direct correlation right there too. It's just fascinating to me that people aren't aware of these things.
Yeah.
Yeah.
Yeah, 100%.
Yeah.
And I mean, this is why some of the, just to just to emphasize maybe some of the this idea of type 3 diabetes, diabetes of the brain, and Alzheimer's being referred to as type 3 diabetes. There I mean, there's a study out of JAMA like a week and a half ago on glycemic variability in people in their 50s and 60s and an increased risk of dementia in the following decades. So, we know that there's a link there. And this is probably why some of the very early signal on widespread use of GLP-1 receptor agonists is showing that there's likely a cognitive protective effect. Some of it almost certainly from glycemic control, and then really interesting, some of it maybe just from an anti-inflammatory component as well. Um, but that link itself of just glucose variability or high glucose and cognitive decline, in the same way that most folks don't think of exercise as being brain healthy,
Mhm.
I would think that that is a link that's not really on the radar
Yeah,
for most people.
yeah, yeah. So how do you morph all of this into your practice now?
Yeah, so we do maybe I'll answer that by giving you a sense of what a journey would look like for somebody coming into the practice. So we meet with them with my team. So we have a care coordinator, health coach, myself, and then the person joining the practice. We'll all get on a call together, start to explore what health looks like. Obviously, like, faces to names and all the logistic stuff we take care of. But really, already just from like minute one, we're starting to dive into what's important to them and what they're really looking to get from working together. Um, we do a comprehensive biomarker panel, so extensive lab testing, genetics, epigenetics, and then really as we get those rolling, that person's going to meet with our health coach in the first week of joining and really just get started on goal setting, motivational interviewing, and getting hooked up into our systems. So one of the biggest parts of my practice that differs from sort of, an executive physical model or like a traditional allopathic doctor is I strongly believe that health is an iterative process and not an episodic process. And to go see your doctor once a year and get some testing done doesn't do anything for the 364 days between those visits. And ultimately, while really well intentioned, like I want to say this, I don't think I've ever met a doctor who went into medical school not wanting to help people, right? But the system is built in a way that those folks end up waiting for someone to get sick. And then once there's a problem, then you have something to kind of dig your teeth into and you can start working on fixing that problem. So we send folks a body composition scale and a wireless Bluetooth blood pressure cuff and a continuous glucose monitor. And we get people plugged into our system to the point where their data is streaming to us in a encrypted, HIPAA compliant way where they don't have to do anything other than put on a cuff and take their blood pressure a couple times a week or step on the scale in the morning. And we know what's happening with them. We are tracking their sleep, we're tracking their nutrition, and we're able to identify trends that we can then work on with them over time. A lot of our focus in the initial phases is on identifying any current, significant health issues, risk stratifying chronic diseases, so cardiovascular disease, cancer, cognitive decline, insulin resistance, or metabolic dysfunction, optimizing body composition to the extent that that needs to be optimized, right? Everyone doesn't need to be running around with abs. Like we're looking for, a good healthy body composition where people are maintaining muscle mass as they age, reducing visceral fat, running their total body fat in a place that's not pro-inflammatory or otherwise impacting their metabolic health. And then as we continue to iterate and we get results back and we meet with folks and we see how they're doing, there are times where further diagnostics are important, like doing a coronary CT angiogram and looking for plaque. Maybe we have identified dyslipidemia and they have a high apolipoprotein B and a high and or a high lipoprotein A, and we want to reduce their risk of a heart attack over time, we may end up deciding, do we need to start a medication to lower your lipids? We've done dietary fiber, exercise, maybe some supplementation. We've modified macronutrient intake. And if we can get to our goal levels, great. And if not, then we have a conversation about, well, let's see, your apolipoprotein B is still high. You've got some plaque in your coronary arteries. This is probably a time where the benefit of lowering your lipids with modern medicine is actually worthwhile. But it's at a point where we've really already gotten a very personalized picture of what that person's risk looks like. And then we can have a very personalized conversation about the risks, benefits, alternatives to different medical interventions. And I'd say we take that approach kind of just continuously.
Yeah, it does sound very comprehensive, and very well thought out rather than just, okay, you have X, we're going to do Y. Do it.
Yeah. No
Yeah.
algorithms.
Yeah. Yeah.
Yeah, no flow charts. And when you said earlier in the conversation that you were taught in nursing school that everybody gets a personalized plan, but then you get out into practice and it isn't like that.
Yeah.
It's a flow chart,
Yeah.
right? And I mean, even for you walk into look on the wall in any of the emergency department rooms, and you'll be very likely to see a sepsis flow chart or
Yeah.
a chest pain flow chart, an algorithm, which is again really well intentioned. It's meant to make sure that people receive standardized care to the point where the quality is standardized
Yeah.
and that things aren't forgotten. And that's, I mean, it's beautiful. That's like nobody left behind, right? I
Yeah.
mean, it comes from a great place, but it is as one size fits all as anything out there.
Yeah.
And, there has to be, I think, a better way.
Yeah. Yeah. It sounds like you found it. Uh, what's that like for, you said earlier it was satisfying, but what is it like doing this kind of medicine instead of running, running, running in that ER all the time?
It's not all unicorns and rainbows, but it's mostly unicorns and rainbows. I take more people off of their antihypertensive medications, their blood pressure medications than I put people on to
Yeah.
medications, right? We've seen just so many people really connect. I guess the biggest satisfier is seeing people connect more with their communities and their families, and seeing them really develop self-confidence and more of a real, like, true to them priority list of what really matters in their lives. So that's phenomenal. Did I get like 6 text messages on the Sunday after Thanksgiving with different questions? I sure did. And that's part of running frankly, a really high touch, high end service where people, that's part of what they get when they work with me. So, yeah, it does, at least I'm trying to think of a reason why the emergency department may have been easier in some ways. And I think that's the only one I can come up with is that when I left a shift, I was off. And
Yeah.
that was that, barring some natural or man-made disaster where I would feel like, okay, this is a mass casualty situation and I need to go back in. I was off when I was off and I was on when I was on. And I wouldn't trade that change for the world. I work from home mostly. For the folks who are in town, I will actually like go meet up or do a house call if they need to be seen in person. For folks out of town, on the phone, on FaceTime, on Zoom, on text message, and I connect with my family way more. I'm present way more. Do I get interrupted at times because there's an urgent issue, or maybe not even an urgent issue, just urgent to somebody, not medically urgent, but just personally urgent? Yeah, that happens. And ultimately, it feels like being a old, like, most listeners may not remember this, but remember like the archetype of the small town family doctor who like knew everybody, like had, the 20-year-old they had like delivered when they were an infant, and they just kind of knew the whole town. It feels like that, except everybody's spread out and we do it over electronics, instead of in person. But I think that's the thing that's kind of the coolest to me, is it feels like being a small town family doctor in a way.
Yeah. That is really cool. That's really cool. For time's sake, we do need to wrap up. Where can people find you if they want to learn more?
I'm super easy to find. So you can find me on Instagram. I'm at Mike Stone MD. No punctuation, just Mike Stone MD. And then you can go to MikeStoneMD.com.
Perfect. Nice and easy. I will include those in the show notes so people can click on that rather than trying to write it down if they're listening while they're driving. Any last words that you want to leave with our listeners as we close up today?
Yeah, I'd say, well, first off, thank you. So much fun getting to connect with you and having this conversation. So really
Yeah.
grateful for you giving me the opportunity to come on. And then for listeners, I would just say whether it's no matter who you find to work with on your health, find someone who will take a proactive approach towards really figuring out what's important to you, and you get a role in participating in figuring out what your health plan and goals look like. And that I am by no means a special snowflake. There are other people out there in healthcare who really want to thread this needle and find that balance of lifestyle intervention and modern, pharmaceuticals and everything in between to help you reach your goals, whatever those may be, and maybe even help you find out what those goals are. So I just really encourage people to that there are better options than the once a year check in for some blood work and eat less, move more. We'll see you next year. So hopefully this is inspirational for folks to start searching for some of those options.
Yeah, I love that. Thank you so much for being here today, Dr. Stone.
My pleasure. Thank you.
Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, and share this with others to help me continue on with my mission to help people live healthier, happier lives. Go to www.brainwellnesssolutions.com to see what I'm up to and get links to all the social medias there. See you next time.